In this lecture, we're going to focus on some of the clinical considerations of acute coronary syndromes, and we'll also examine some of the complications that result from myocardial infarctions. And so one of the first elements to evaluate is, the possibility of an acute coronary syndrome is to first take a patient history of these symptoms. And this often begins with asking the patient if they've ever experienced any chest pain or any angina, and at the same time, other questions related to any history of chest pain, which includes frequency, intensity, duration of those episodes of chest pain, as well as assessing what the patient was doing when those chest pains emerged. Other signs and symptoms would be evaluated at the history stage, which includes asking the patient if they've ever experienced any gastrointestinal disturbances, any abnormal breathing, sweating, anxiety, or any lightheadedness or instances of fainting, which is syncope. And it's also important to note that approximately 25% of the cases of MI are silent MIs, in which the patient does not experience any pain. At this point, the clinical examination would move on to a physical examination. And one of the concerns here is something called systemic hypotension. And that is a low blood pressure that would occur from a rapid and overall vasodilation of the vasculature. Noting any diaphoresis, which is excessive sweating on the part of the patient, whether the patient is experiencing what's called sinus tachycardia, which is basically a very fast resting heart rate. Tachypnea is the definition for rapid breathing. And so this is where the patient is just sitting in a resting position, and are they demonstrating a rapid rate of breathing with a reference that approximately 10 to 20 breaths per minute is what is considered to be the normal range of breaths a person would take. Are there any abnormal heart sounds as detected through a stethoscope? And so these include any third or fourth heart sounds, or any murmurs that may exist. And murmurs arise when there's sometimes a regurgitation of blood back into a heart chamber. And then there are a range of other tests that are carried out fairly rapidly to determine whether a person is experiencing an acute MI. And these tests include blood measures of cardiac troponin, so CTN, electrocardiogram recordings, any chest radiographs or blood tests that would indicate any other marker of myocardial cell damage. And before we get into the complications associated with MI, it's important to examine and review the electrical conduction system of the heart. And the electrical conduction system of the heart is carried out by a very specialized set of myocytes. And these are myocytes that do not generate muscle force. So these are not myocytes that are generating the pressure to push blood through the heart and out of the heart, but rather these are the myocytes that generate electrical signals that coordinates the contraction phases of the heart. And this all begins at the junction of the vena cava and the right atrium. And so embedded in the wall of the right atrium is a small collection of specialized cells called nodal cells. And these nodal cells serve as what's called the pacemaker of the heart, collectively just simply called the sinoatrial or SA node. And these cells have a high rate of what's called automaticity, and that these cells can generate their own electrical signal repeatedly and reliably on their own. And when these cells generate an electrical signal, that electrical signal spreads throughout the right atrium and very quickly over to the left atrium. And this will coordinate the near simultaneous contraction of both the right and left atrium together. As that electrical signal travels throughout the right atrium, that electrical signal will travel to the cluster of cells at the most inferior part of the right atrium called the atrioventricular node. So in a very similar structure to the SA node, these are made up of these specialized, what are called nodal cells. And these nodal cells, when receiving this electrical stimulus, will pause and reactivate and will send that electrical impulse through a long string of connected electrical conduction cells through what's called the bundle of His, or just simply referred to as the atrioventricular bundle. And that atrioventricular bundle will move from the right atrium towards the ventricles and will split into two branches. And these are just simply called the right and left bundle branches. And the right and left bundle branches will then further extend into this, what appears to be this network of electrical transmitting cells that will result in the eventual activation of the ventricles. And this network of electrical conducting cells, once it reaches the apex or the most inferior portion of the heart, is called the Purkinje system. And the Purkinje system, or the Purkinje fibers, will transmit those electrical signals very quickly, in fact, much faster than the electrical transmission from SA to the atria, to the AV node, to the bundle of His, down the bundle branches, and eventually into the Purkinje fibers. So when we see this rather intricate yet very reliable and consistent electrical conduction pathway, can experience pathologies as well. And one of the complications of a person that has experienced a heart attack or myocardial infarction is what's called an arrhythmia. And an arrhythmia is a condition where that normal electrical transmission that we just reviewed on slide 11 is not going through that normal pathway. It's undergone some change due to some particular pathology. And if it's a complication of a myocardial infarction, it's likely that the arrhythmia arose because of the damage to some of those electrical conducting cells. So one type of arrhythmia, or one class of arrhythmias, are just simply referred to as supraventricular. And these are arrhythmias, these pathologies in the electrical conduction system that originate superior to the ventricles. And so one type of arrhythmia is what's called a sinus bradycardia. And this is simply a low resting heart rate. And this could result from a few different issues that are complications of MI. It could result from an increase in what's called vagal tone. The vagal tone refers to cranial nerve number 10, the vagus nerve. And the vagus nerve, when activated, which is the branch of the parasympathetic nervous system, will decrease heart rate by reducing excitability of the SA node. So that's one of the mechanisms that would be responsible for sinus bradycardia, excessive activation of the parasympathetic nervous system, which operates through the vagus nerve. Another factor that could result from that, or that could account for the bradycardia, is SA node ischemia. And so if there was any reduction in blood flow to the right atrium that affected these nodal cells, then that could result in a slowing of the activation of the surviving cells to generate that heart rate, and that heart rate would be lower. Another arrhythmia is sinus tachycardia, which is a fast resting heart rate. And this could result from a number of conditions. And these are just three examples, in that if a person is acutely experiencing pain, that will activate the sympathetic nervous system and accelerate heart rate, as will heart failure. And so if a person in a condition of heart failure, the heart will attempt to continue to move blood by beating faster. An increase in sympathetic tone refers to a relatively constant increased activation of the sympathetic nervous system. And when the sympathetic nervous system has increased its activation, one of the effects is that it will accelerate heart rate. Another complication of MI is what's called atrial fibrillation. And atrial fibrillation refers to the contraction pattern of the atria. And so this is a very abnormal pattern of contraction that in many cases is considered to be an emergency situation. And so this is an uncoordinated fluttering type of effect that the atria have. And so instead of the atria performing one cyclical contraction followed by a relaxation, the atria would contract contract to a very small magnitude and relax very quickly, contract very quickly, relax very quickly, much like a sheet fluttering in the wind. So that's just one analogy here to explain atrial fibrillation. And so that results from this change, this pathology in how the electrical signal is transmitted to the atria. Then there are the ventricular arrhythmias, and the ventricular arrhythmias affect specifically the two inferior chambers. And one type is what's called ventricular fibrillation. Ventricular fibrillation is particularly more concerning, and certainly an emergency situation, because if the ventricles are fluttering and not contracting forcefully enough in the normal contraction relaxation cycle, blood will not flow through to the systemic circuit, and of course not through the coronary circuit. And if blood flow is interrupted towards the myocardial tissue will certainly result in damage. Ventricular tachycardia, by definition, is a fast rate of ventricular contraction. And another arrhythmia that afflicts the ventricles is what's called premature ventricular contraction. And this occurs when there is an electrical signal that would trigger the ventricles contract before the actual contraction of the atria. And this all produces a very inefficient way for the heart to distribute blood to the entire body. Another complication of myocardial infarction are what are called simply conduction disturbances. And conduction disturbances is a type of, it can be considered a type of arrhythmia that affects the electrical conduction system. One type is called an AV block. And this is referring to the atrioventricular bundle, the bundle of His. And so if that tissue, those small sets of specialized cells, have been damaged as a result of a heart attack or an MI, the ability for that entire conduction system to transmit to the ventricles becomes adversely affected. And so that will result in a delay in the transmission to activate the ventricles. The bundle branch block refers to damage to the electrical conducting cells distal to the bundle of His. And those are the bundle branches, the right and left bundle branches. And recall that from slide number 11 on the diagram, the bundle branches will transmit the electrical signal to the right and left ventricles through the interventricular septum, that myocardial tissue that separates the right and left ventricle. The right bundle branch tends to be affected here more than the left bundle branch. And then there's something called post-infarction syndrome. And post-infarction syndrome results in conditions that are not directly tied to the contracting myocytes or the electrical conduction cells. And one syndrome includes what's called pericarditis, inflammation of the outer layer, the pericardium, that outer sac that surrounds the heart and connects the heart to the elements of the thoracic cage. And a more chronic level of chest pain is seen as has been observed to be one of the complications of myocardial infarction. So that ends this lecture on the clinical and complications that result from myocardial infarctions.